Go. There we go. Welcome everyone to Ovarian Cancer Canada speaker series on ovarian cancer and medical cannabis. My name is Marianne Follis and I'm the Programs Associate with Ovarian Cancer Canada, and it's my pleasure to be here with you tonight as your host. Tonight's call joins together people from across Canada. I recognize and respect that these are the unceded traditional lands of many diverse First Nations, Inuit, and Métis peoples. I'm calling in tonight from Guelph, Ontario, which is situated on the ancestral lands of the Attawandaron, Chinootan, and Anishinaabe and Haudenosaunee peoples, and the treaty lands and territory of the Mississaugas of the Credit. My acknowledgement of the land is my declaration of responsibility and commitment to continual learning about this land and its peoples, histories, rights, and presence. It's my pleasure to introduce you to our speakers for this evening. Dr. McGee. Dr. McGee is a gynecologic oncologist and associate professor in the Schulich School of Medicine at Western University. He completed his gynecologic oncology fellowship training at the University of Toronto after residency training in obstetrics and gynecology at the University of Ottawa. He has a master's in public health from the Dalla Lana School of Public Health at the University of Toronto. He is the regional gynecologic oncology champion for Southwestern Ontario, a director for the Gynecologic Oncology Group of Ontario, and the Secretary-Treasurer for the Society of Gynecologic Oncology of Canada. His research interests include optimizing testing for hereditary cancer syndromes and outcomes research using Institute for Clinical Evaluative Sciences datasets. Welcome, Dr. McGee. Joining Dr. McGee, we have Dr. Black. Dr. Black is a first-year gynecologic oncology fellow at the University of Calgary and is concurrently taking the Master of Public Health program at the University of Victoria with a focus in Indigenous Health Studies. She completed a Bachelor of Science in Biochemistry and Medical School at the University of Saskatchewan, followed by an OBGYN residency at the University of Alberta. Her research interests include enhanced recovery after surgery and improving perioperative outcomes, Indigenous health, and cannabis use in gynecologic oncology. Welcome, Dr. Black. And rounding out our panel today is Renée Resendes. Renée is a clinical research coordinator at the London Regional Cancer Program. She completed a Bachelor of Science in Biology with a double major in chemistry and biochemistry at Lake Superior State University, followed by a Master of Science, research-based, specializing in developmental biology at Western University. Her current research portfolio is in gynecologic oncology with a focus on ovarian cancer. Welcome, Renée. We have a wonderful group of speakers here to share their knowledge with you tonight, and so I will turn it over to Dr. McGee.
All right, thanks. See if I can share here. So, do you guys see it?
We can.
Great. So for those who don't know me, my name's Jake McGee, Dr. Jake McGee. I'm a gynecologic oncologist from Western. I'm going to be honest with you, I'm repurposing a little bit today in that I'm sharing some of the slides I used in a talk I gave at McGill University a couple of weeks back. Now, the title came from a friend of mine I coach hockey with, and when I told him I was talking about medical cannabis to McGill, he said it should be all right, and it comes from Dazed and Confused. So I don't know, there might be some older people on the line that know this movie. It's Matthew McConaughey. It's from back in the day when he didn't own a shirt. So fortunately today he's got one, so he's obviously done well. But it's a movie where cannabis features fairly prominently. Now, my residents asked me why I was giving the talk to McGill a few weeks back, and I invoked Oscar Wilde, who said that an expert is an ordinary man away from home giving advice. Considering that I'm in the office right now, I suppose that might qualify as me being away from home. And I'm talking to you about a topic for which I have acquired some knowledge through work that I've done through the Society of Gynecologic Oncology of Canada, through our community of practice in medical cannabis. But I'd say it's a stretch for me to say that I have true expertise in this area. However, I am availing some of my patients to medical cannabis. And this is the I don't know what this is called, but the little video that he sent me, the beautiful Matthew McConaughey from Dazed and Confused. So in terms of conflicts, these are my entanglements, and none of which have a whole lot to do with today's talk. I will say, though, that the educational grant that we received from Spectrum Therapeutics was utilized by our COP to put together a webinar, and we are embarking on a national patient survey, which Renee is going to talk to you about in a little bit, with some of the funding paying for that research support that's required to navigate the REB process and launch the study. And I'd just like to acknowledge my collaborators in the COP, people who have really stepped up to do some of the heavy lifting. So Dr. Rochelle Finley, Dr. Elena Igwe, Dr. Jian Zhang, and Dr. Kristin Black, who was kind enough to give us some of her time tonight. So this talk is really a synthesis of some of that webinar work, and I've taken some of the content for slides today for this presentation. So, fun aside, cannabis, it's a serious drug, and it has consequences. And with legalization, we are witnessing what I would call kind of a real-time observational experiment, if you will, about what happens when new segments of the population start taking a drug. So after caffeine, alcohol, and tobacco, it's the most utilized drug worldwide. So what we're going to talk about today is really a broad overview, and there's a lot to cover. And hopefully by the end of it, you're not going to feel like you've been fed through a fire hose. Within each of the categories, I'll give some objectives as we get to them for what I hope you might take away. As far as clinical evidence for use, you have to remember that, this call, the people on this call are working in gynecologic oncology. So we look at applications through the eyes of people who treat cancer and the accumulated toxicities of things like cytotoxic chemotherapy, and someone who values good palliation for patients who do see their disease progress. Now, some of our patients, which are really you guys, are using cannabis, and as physicians, we can't really get around that. I put it in the category of integrative medicine, so things that patients are doing or taking that they believe have health benefits, and which they likely do, but for which the evidence really isn't as robust as we'd like. Having a working knowledge for clinicians makes us functional in the clinic when we're confronted with questions about the role of cannabis in a given situation, and for patients, it empowers you, gives you some options as you deal with the myriad of symptoms you might experience as you move through your cancer journey. And if none of this grabs you and you've turned into the wrong webinar, please stick around, and maybe you'll learn enough today that you'll be interested at a party sometime. So let's jump into it. So in this portion of the talk, we're going to get into a little bit of the pharmacology of the endocannabinoid system. And we're going to differentiate between different cannabinoids and where they arise. And we're going to talk a bit about the difference between things like THC and CBD. And then we're going to review the pharmacokinetics of cannabinoids. So if we want to talk about these things, we'll have to get on the same page, and there's some terminology that we have to try and get our heads around. So there's different types of cannabis, and sativa and indica are the most common. There's also something called ruderalis. So sativas as a strain, these are more uplifting, they're energetic. If you were using these, you'd want to use them during the day. Whereas the indicas, they can be more sedative, and regular users are going to tell you that the indicas leave you in the couch. So they're going to kind of knock you out. And I think Daffy and Bugs here show you the differences between the effects that they can have. Daffy is using a sativa, and Bugs is more in an indica. So keep that in mind if you do decide that you want to partake or experiment with some of these medications. If you want to sound like you know what you're talking about, and you find yourself in one of the many shops in Ontario, there's more cannabis purveyors than there are Tim Hortons in any given city, then you would talk about type 1, 2, and 3 within each strain. And this relates to the amount of THC primarily. And for medical purposes, you're going to want to stick to the type 1 strains where the THC concentration is lower. The type 3 strains, they're liable to send you to the moon, and that side effect will likely outweigh any hoped for medical benefit. There's also hybrids, and if you go into any kind of shop, they can talk to you about those. So THC is tetrahydrocannabinol, and cannabidiol is CBD, but it's easier to use the acronyms. So where the cannabinoid comes from is derived from the first part of the word. So the endocannabinoid are endogenously produced naturally by the body, and there's two main types, so anandamide or 2-AG, and phytocannabinoids come from plants, and the synthetics are cannabinoid products that are manufactured in the lab. So as you can see from this slide, the body is littered with endocannabinoid receptors, and the two main being CB1 and CB2. So CB1 receptors dominate in the nervous system, and CB2 are more associated with the immune system. But as you can see, there are receptors in most tissues throughout the body and even in the skin. In view of the receptor distribution, it's really not a surprise that the use of cannabis has profound impacts on both the body and on the brain. So this is a couple of neurons and a synapse in between, and this is really complicated, but it's worth looking at because it talks to how nuanced the endocannabinoid system is within the body, and it hints at what can happen when we decide to utilize cannabinoids. So what happens? The endocannabinoid is produced on the postsynapse. So down here, it gets launched back up, and it results in a cascade of neurotransmitters, things like GABA or dopamine or 5-HT or glutamate. And these can either be excitatory or inhibitory. And when we utilize medical cannabis, then we really flood the system in a way that the endocannabinoid system does not. So from the cannabis plant, we get the marijuana flower, and these are the dried leaves and the flowering heads, which contain more than 500 chemical compounds. And these can be divided into the phytocannabinoids and then the non-cannabinoids. And these are things like terpenes and flavonoids, which when taken together from the flower provide the so-called entourage effect. So the combined effect of all the chemicals that are in the cannabis plant versus when something is produced in a laboratory or is isolated out from the constituent plant. So where the effect of any of the constituent chemicals enhanced by the other chemicals, this is the entourage effect, and it may contribute to some of the purported antioxidant or anti-inflammatory, even the anti-cancer effects. Terpenes vary across the various strains, and these are responsible for the taste and the fragrance of the plant. Now, I live by Western University, and there are lots of students around, and my kids think that our area is infested with skunks because when they were younger, that's what I would tell them they were smelling. Now, these things like the terpenes and the flavonoids, they may also contribute to the type of high that someone gets if they're smoking cannabis, and it might modify some of the effects of the phytocannabinoid. So in their plant forms, these phytocannabinoids are inactive, but to activate them, they need to be heated somewhere between 100 and 200 degrees. And the higher the heat, the faster the decarboxylation happens. And as the temperature increases, then some of that THC can actually burn off, but it will decarboxylate faster. So THC, this is the component of the plant that has a psychoactive effect. It can cause a mix of stimulant and depressant effects, and it might elevate mood or enhance relaxation, stimulate appetite, but it might also cause paranoia, depression, anxiety. And physically, you can tell when someone has been using cannabis because they'll have hypertension and a tachycardia. So how CBD does its thing is not as well understood. It doesn't bind at CB1 or CB2, but it might be a modulator of CB1. And there's a long list of effects that are attributed to CBD, things such as anti-inflammatory effects, antiemetic, antipsychotic, anti-ischemic, anti-epileptiform properties of the marijuana plant. And these things interact together. So the effect of the medicine can be impacted by the order that these are taken and by the relationship of the ratio between CBD and THC. And it's thought that, or it's known that you want to keep that ratio of CBD high to THC if you want to minimize the high effect and try and focus on some of the other purported health benefits, and we're going to talk about the uses in just a second. So I'm going to talk just briefly about pharmacokinetics. This is kind of what the body does to the drug once you take it. And as this slide shows, it's pretty complicated, but just think about it as absorption, distribution, metabolism, and excretion. So there are 4 ways that we can absorb, and for cannabis, the most common method would be smoking or oral. So when we inhale cannabis, it has a rapid onset of action because the alveoli, the small air sacs in the lungs, are so well perfused that the effect can be felt within minutes because the drug literally gets right into the bloodstream. With that, though, there is variable bioavailability, which is the amount of drug that someone has in their bloodstream. And that really relates to how well someone can inhale. And so in this regard, a frequent user, an experienced user, is more likely to get a higher blood concentration relative to someone who is new to smoking cannabis. And when we inhale it, you only get a partial about a quarter of the THC content of the drug. The next most common way is to ingest it, and that would be the oral route. And this could be tablets, could be oils, could be edibles, could be prepared foods with cannabis in them. And the effect here is over hours, since absorption takes place across the gut. For prescription medications that are oral formulations, things like Sativex, the bioavailability is consistent due to the processing, whereas if it's a cannabis-based food that you've prepared yourself or that you've purchased, the bioavailability is less, and this likely relates to the fact that chefs at home haven't quite mastered the science of the cooking the way the industrial producers can and have. So once we absorb it, it gets distributed primarily into our fatty tissues, and the highest concentrations end up in your heart. The blood-brain barrier actually keeps concentrations relatively low in the brain, but it does eventually cross. And then in terms of metabolism, so Kristin, I think, will probably talk a little more about this in terms of its relationship to other drugs, but it's metabolized in the liver by something called the cytochrome P450 system. And it can impact the effects of other drugs there. When we consume orally the drug, then it goes to the liver, and there it converts to this thing called 11-hydroxy delta 9 THC. And this can cause a different type of psychoactivity or high, if you will, relative to smoking the drug. When it's smoked, within 15 minutes, the onset of action is there, but when it's consumed orally, it might take an hour longer for the effects to be seen. And then our body excretes it. So after it's smoked, these things go into our urine, they go into our feces through our gut. And with oral consumption, it's primarily through the gut. Keep in mind that the half-life of THC is about 4 days. And for a drug to get out of your body, it takes 5 to 7 half days to get out. So it can take upwards of a month for cannabis to completely leave your system. So that was a lot, I know, but just to summarize, so THC has a greater psychoactive component when compared to CBD. There's lots of variations in absorption, and it depends on how you take the drug. It is highly lipophilic, and it has a wide volume of distribution throughout your body. It could interact with this thing called the CYP P450 system, and your physician would think about that as they're prescribing, or at least be aware. And slow body clearance happens despite quick loss of the active metabolites in your body. Okay, we're going to jump over to clinical evidence for use now. So here are the objectives. We're going to talk about some of the limitations in the medical cannabis literature. We're going to develop an understanding of the pharmacodynamic effects of cannabis. We're going to familiarize ourselves with the preparations just briefly, and then we'll look at the oncologic application of cannabis-based medicines. So before we get into the evidence, I just want to let you know that cannabis poses some particular challenges when it comes to research. We only in the last few years have had access to medical cannabis, and there's still a relative stigma surrounding it. Furthermore, standardizing any of the inhaled formulation is made difficult by the fact that many participants, which are you guys, might not be experienced cannabis users. So standardization of drug and drug delivery is difficult, as is blinding, which is, not telling you what formulation that you're taking. For the available literature, there's lots of different study methodology. So these are things like who we include in the studies, what we use as our comparator, the formulations or the drug that were used in the studies. So with this being all over the place, it's hard to really synthesize it down and figure things out. we know that kind of the horse is out of the barn, and patients don't need us as physicians to access the drug. They can access it from just about any strip mall, at least in Ontario. And so the good news is there will be more studies that happen, and we'll do our best in the medical side to try and figure out what the real role in terms of medical usage is for cannabis, and it's going to relate to specific populations or be different for specific populations when we do that. So we've already talked about the pharmacokinetics of cannabis, but what about the pharmacodynamics? And that's what the chemicals in cannabis do to us when we consume them. So here you can see that things like analgesia, the antiemetic, the anti-inflammatory effects are realized with both THC and CBD. Just as a review, remember that THC, it has maybe some antiemetic and some antioxidant effects, along with the effect of altered sensorium, or the sensation of being high. CBD, on the other hand, has antipsychotic and anxiolytic effects. And then remember, we spoke about the flavonoids that cannabis is filled with, and these are the secondary things, plant metabolites, and likely the source of the anti-cancer properties of cannabis. You don't need to hang out long in an oncology clinic before you'll find a patient who asks you about the anti-cancer properties of cannabis, or who is taking a formulation that they've either prepared themselves or they've gotten from someone. There's a whole bunch of doses here. In terms of what's available, dronabinol, which is a synthetic opiate that we used to be able to prescribe, is no longer available. Nabilone is available. Nabiximols and Sativex, this is a buccal spray of THC and CBD, and this is one that I prescribe to patients if they are not interested in obtaining cannabis on their own. It has the advantage of lower blood levels of THC relative to smoked cannabis. And just to give you an idea about costs, it costs about $125 per vial, and you get 51 sprays of that. And a chronic pain user would use about 5 sprays per day, so it would cost about $12 a day. And my prescribing of this has been influenced by work that I've done with a chronic pain specialist here in London. So the inhaled forms of cannabis, these are the dried flower. You can vape, you can use these things called dabs. They're not, inhaled formulations are not as frequently used in studies, but this might represent the form that, many patients will initially try. And particularly if they're coming at it as an experienced user. The advantage, as I mentioned, is that it's a rapid onset within 5 to 10 minutes and lasts maybe only 2 to 4 hours. The disadvantage, though, is relates to the possible respiratory effects and throat irritation of smoking. And then you have oral formulations. So these are things like edibles or tablets or capsules or solution. These avoid the pulmonary irritation, but they take a little bit longer to come on and have their onset of action, about 1 to 3 hours. Here you can see that a number of organizations have published reviews and related to cannabis. And I would encourage you to, this is worth looking at reputable websites if you want to try and gain more information. In terms of where I see a role for medical cannabis, I'm a gynecologic oncologist, so my interest lies in evidence pointing to its effectiveness in oncology-related conditions. So I'm just going to talk real briefly, high level. We're not going to get into the weeds as far as the types of studies that were conducted, but where there is evidence, and that relates to things like its role in pain control, chemotherapy-induced nausea and vomiting, appetite or anorexia as a stimulant, and then for palliation for patients who do have their cancer progress. And then we'll talk just briefly on anxiety and sleep. So there are multiple types of pain that a cancer patient might experience, and cancer pain is just one. So there's chemotherapy-induced peripheral neuropathy, peripheral neuropathic pain, and various types of acute and chronic pains. Typically, we use multimodal analgesia as we approach this. So we start with things like Tylenol, ibuprofen, maybe narcotics, and then we might add in something like gabapentin or pregabalin. And I'll just take a quick word to mention that, placebo medication. So we tend to understate the role of placebo, and sometimes we even use it as a dirty word. So I had the opportunity to participate in a talk recently with a chronic pain doc who spoke about neuroimaging studies of placebos and studies that compared them to the impact of low dose opiates for patients with chronic pain. And this speaks to potentially, turning on the brain, if you will, with something, in this case, medical cannabis, to alleviate symptomatology. So with recent cannabis studies, what they found is that there's a correlation between effectiveness of the drug and the amount of positive information abounding in the popular press. They've started doing studies where patients are given a cannabis gummy versus a placebo that smells like cannabis but doesn't have any of the active metabolites. And the results show similar effect, favoring both the cannabis and the cannabis smelling placebo over placebo. So depending on the type of symptom I'm helping a patient treat, I don't have a placebo that I can give them, but I can prescribe medical cannabis or point them in that direction. So if we look at national research bodies, the National Academies of Sciences, Engineering, and Medicine state that there's conclusive evidence for affecting chronic pain for oral cannabinoids. The Canadian Agency for Drugs and Technologies and Health state that there's some suggested benefit for cannabis-based medicines for neuropathic pain. And Cochrane Library states that there's high quality evidence in any condition with chronic neuropathic pain. And you'd probably consider these maybe as third-line therapy. However, the side effects might be favorable to things like narcotics and are definitely worth a consideration. Another area where cannabis can play a role is chemotherapy-induced nausea and vomiting. So the literature in this area is dated and doesn't compare any of the new medications. So these drugs like ondansetron or aprepitant that are built into regimens for chemotherapy. And these are kind of first-line rescue medications. But when it comes to chemotherapy-induced nausea and vomiting, there is conclusive or substantial evidence for effect. And both NASM and CADIS says that we can consider these medications. And Cochrane says that they may be useful. And in fact, if you look back at the studies, many of these medications were compared directly to things like ondansetron, not used in combination, but compared to. And so in that regard, these are, ondansetron is quite a powerful medication. These 5-HT3 antagonists work very well for chemotherapy-induced nausea and vomiting. But the addition of some medical cannabis is definitely something to consider for patients who are maybe suffering from some of the side effects of these medications, constipation being one of them, or who want to have a rescue medication that they use when needed and is readily available to them and that they can control. So patients that are being treated for ovarian cancer, they often have decreased appetite and oral intake. Unfortunately, there's not a lot of evidence in favor of this. By the time a patient gets to the point in their cancer trajectory where they're having decreased appetite or oral intake, I might be offering cannabis as a treatment for a whole host of reasons. So you can say that they derive some benefit on the appetite side as well, but that might not be the primary reason why it's being prescribed. I find that patients, they're not usually as bothered about the loss of appetite as the family members that are around them who, find it quite distressing to see their loved one stop eating. Which brings us to palliative medicine. I think cannabis-based medicines can work really well for patients who end up following this trajectory with their disease, because it does help address a whole range of symptoms that patients suffer with near the end of life. And Dr. Sear, who's from Montreal, has published a Canadian-based guideline that outlines the challenges that we as clinicians need to consider, such as when do we offer it, how do we manage expectations about what cannabis can really help with in terms of symptoms, and then considerations around the level of experience of the user, and then things to think about in terms of precautions or contraindications, which we're going to talk about in a little bit. In terms of palliation, I like to involve the palliative care team quite early for a patient that does have progression of their cancer. I'm still involved in the clinical management, though, for these patients. And for them, I as I mentioned, I don't I raise it, and if a patient finds it to be something that might potentially be appealing, then we go down that rabbit hole, if you will, sometimes of what medical cannabis might do for them. And then as a cancer treatment, it's not quite ready for prime time. Cannabis-based medicines are not there, but the pharmacologic effects of cannabis, as we've learned today, are really far-reaching, and the impact is seen in just about every organ in the body. And certainly in the basic science realm, there's lots of evidence for anti-cancer or cannabis as an anti-cancer treatment. It affects things like apoptosis. It inhibits proliferation or angiogenic or blood signaling development of new vessels, and it can do many different things. So there's definitely evidence for it there, but as a treatment, it's not quite there yet. And then there's a few non-oncology conditions that I'll just talk to briefly. I've probably talked too long here, sorry. Anxiety. So when I showed that earlier, that G protein receptor, keep in mind that the endocannabinoid system, when our body produces these natural cannabinoids, they kind of tickle the receptor. They're very low doses. But when we take cannabis, it floods the system, and so it floods or inhibits those neurotransmitters. And so many patients will find there's an exacerbation of their anxiety. And then as far as sleep is concerned, there's some good evidence for using cannabis for sleep, and we've seen it for a whole host of conditions, including chronic pain. And I'll just say that if you are considering using cannabis-based medicine to help you with sleep, keep in mind that you want that THC or CBD to THC ratio to fall well on the side of CBD. Otherwise, you're going to rob yourself, or a physician will be robbing their patient of REM sleep and potentially causing other issues. So cannabis, it has analgesia, antiemetic, anti-inflammatory effects. Cannabis-based medicines are not first line for treatment for any cancer-related symptoms, but they might play a role in association with other medications for a gynecologic oncology patient. And there's good evidence for chronic pain, for neuropathic pain, for chemotherapy-induced nausea and vomiting. And there's good rationale for using it in the palliative setting, and also likely for sleep. So I hope that what I've just told you kind of enhances your knowledge around the biology of cannabis, some of the potential applications in the medical world. Kristin is going to get into more how we prescribe it and some of the potential issues patients may experience. As these medications continue to gain acceptance, their applications will broaden or at least solidify how we as physicians can use them to help improve patient satisfaction and well-being along the way. So thank you, and I'll turn it over to Kristin. And happy to take any questions at the end.
Great. So I feel like after all of that, I have kind of the easier part, but I'm going to talk about the logistics of if you're someone who maybe you're out there thinking you're interested in learning more about medical cannabis, or whether or not this could be right for you, what are the actual logistics around, how do you access cannabis? What's the best way? Are there any contraindications to accessing it? And all the legal implications. And so I have no conflicts of interest to disclose. And so these are my objectives for my portion of the talk. Is we're going to talk a bit about the legalization and regulation of cannabis in Canada. Talk about, and Dr. McGee already sort of touched on this, but we'll just briefly review the types of cannabis that are available and discuss any contraindications or reasons that you would not want to be considering cannabis and potential drug interactions and some of the side effects. So in Canada, the initial regulations for medical cannabis use were introduced in the 90s. And in 2013, these were modified to include regulations over the commercial industry of producing medical cannabis. And then in 2015, these were modified to include things other than just the dried plant cannabis. So these include things like oils and capsules and other things. Right now, these are our most recent guidelines, the regulations, or the access to cannabis for medical purpose regulations. They come down from Health Canada, and these were created in response to the legalization of recreational cannabis in Canada in 2018. And so they provide oversight and regulations for the production, distribution, and quality assurance of medical cannabis, including people who may choose to grow their own medical cannabis. And it's important to note this is different from the Cannabis Act, which in Canada regulates the recreational use. So, but logistically, how does someone actually go about getting medical cannabis? The first step in this whole process is seeing your healthcare provider and determining if cannabis could be appropriate for you. And if the healthcare provider thinks you may have a condition that you may benefit from medical cannabis, they give you your medical documentation, which is essentially the prescription. So the one route is to register with a licensed producer. And so this is a commercial body that you register with them with your medical documentation, and they then send you your cannabis products in the mail based on, and the types that they actually send you is based on what you choose. Or if you're someone who has a bit more of a green thumb, you can also grow cannabis with starting materials that you purchase from a licensed producer. So this can be cannabis that you grow in your own home, or you can designate someone else to grow it for you. So these are the options for how to obtain medical cannabis. And so these are different than anyone can just walk, like I can walk down the street right now 2 blocks from my house and buy any sort of cannabis products at the recreational store. These are different than those recreational stores. So the medical cannabis that you would purchase from a licensed producer can only be mailed. And so there is, depending on how much a person is using, how frequently you're using it, there can be significant costs associating with using cannabis. And that'll vary widely depending on where you're purchasing it from and how much you're using and how frequently you're using. And it's not covered by any government insurances, but some private insurances may have some coverage for it if it's prescribed by a physician. And so this is an example from Health Canada of the medical documentation, which is essentially the prescription that your healthcare provider fills out with your information, their information, the amount of cannabis they're authorizing, and then how long the prescription is valid for. So the maximum Health Canada allows it for is up to a year. There's a few different types of cannabinoids available in Canada. So on the left, as we already, Dr. McGee talked about, you have Nabilone, which is a pill, or Nabiximols or Sativex, which is a spray, and then all the various formulations that you can find of the actual cannabis plant. So there's a variety of different ways that a person can use medical cannabis. And I tried to just break this down to think of some really simple, if you're someone who's brand new to this area and you really don't know much about the different ways a person can use cannabis or why you would pick one than the other, something like smoking or using a vaporizer is good because it has a really, really quick onset. But some disadvantages of something like smoking are that it has those toxic byproducts, similar to smoking a cigarette, that it produces carbon monoxide and other toxic byproducts that you're then inhaling into your lungs. So a vaporizer is beneficial because it avoids that. There are also a variety of oral ways that you can use medical cannabis. So you can purchase like pre-made edibles, which can come in like all sorts of things like cookies and brownies. You can get pills or capsules or oils that deliver a known dose. Those have quite a bit of a slower onset of action, so it takes up to a few hours for the effects to actually set in. And then they usually last, depending on the dose, anywhere from 4 to 8 hours. Similar, the oral spray has a slower onset of action. And then some less common ways that you may hear about are using rectally or transdermally. And so transdermal means through the skin. It's something that's not very common because your body doesn't take up the cannabis really well through the skin. But it theoretically is a way to get a constant low dose of cannabis, but more research is needed in that area. So there are a few reasons that we would say cannabis is not appropriate for certain people just because of the risks that are associated with it. So people who are under the age of 25, we know that their brains are still rapidly developing. They're growing neurons and making all these neural connections in their brain. And we know that cannabis affects those neural connections in the brain. And we don't know all of the potential long-term consequences of that, but there's some evidence to suggest that can increase a person's risk of schizophrenia or potentially other mental health conditions down the road. So because of that reason, cannabis is not recommended for patients under the age of 25, or if they have a personal or family history of psychosis. If anyone has a current or past history of cannabis use disorder, if they have cardiovascular or respiratory disease, cannabis is not considered appropriate because of the potential side effects of smoking or the risk of heart attack. And if someone is pregnant, planning on becoming pregnant, or currently breastfeeding, there are potential side effects associated with cannabis use. And then they say that cannabis should be used with caution in people with concurrent mood or anxiety conditions, in people who smoke tobacco or have other risk factors for cardiovascular disease. And then other things such as alcohol and opioids or other sedating medications can sometimes make cannabis use can make the effects of that more. So people may become more drowsy, more sedated, more intoxicated than they intend to be if they use those together. And so a very important thing and another important reason to talk to your healthcare provider if you're using cannabis or if you're thinking about it, is that because of the enzymes in your body that break down the THC and the CBD in your body, it can have drug interactions with certain medications. So for example, some drugs, if you're taking them, can increase the THC levels in your body, which could end up in you being more high, for lack of a better word, than you intended on being. And also importantly, the opposite is also true, that the THC from the cannabis can affect the drug levels. So an important example of this is warfarin, which is a blood thinner. It can affect the warfarin and make your blood even thinner than it is supposed to be, or it can affect some seizure medications. It can also affect drugs so that then the drug doesn't last as long. And then, as we mentioned, it can have some interactions or make you extra drowsy or sleepy if you use it with opioids or alcohol. And why it is very important to talk to your healthcare provider about using cannabis. Some short-term, so these would be things, side effects that would last, just a short duration of time. So just a matter of hours to days. Sometimes people, when they use cannabis, can describe some drowsiness, dizziness, confusion, some decreased ability to pay attention or judgment or make decisions. Some people may experience some hallucinations or anxiety. People may experience some tachycardia or like feeling like your heart's racing, or even have some irregular heartbeats, and get a lower blood pressure, which in those who are at increased risk can put them at risk of having a heart attack or stroke. And some other side effects people may experience are things like dry mouth, nausea, and it can slow down the food leaving your stomach, so it can make you at slightly higher risk of feeling nauseous or throwing up. And then there are some longer term side effects. And so some of these we've already touched on, such as worsening of certain mental health conditions or increasing your risk of schizophrenia in those who are younger. And there's a little bit of studies that have suggested there's potential for lower IQ in younger people who use very frequent marijuana, and neurodevelopmental effects with fetal exposure. And then very specific to smoking are the respiratory side effects. So chronic cough, wheeze, increased rates of pneumonia, potential for increased risk of lung cancer if you're a regular cannabis smoker. So in general, so if you've decided you're going to try cannabis and you've talked to your healthcare provider and you don't have any of those contraindications, it's different than just going to the pharmacy and picking up a bottle of Tylenol and taking the standard Tylenol dose. There's actually not really one set low dose of cannabis. It's actually really, really specific depending on the person and if you've used cannabis before or not. And as we've talked about, there's different types of strains that are out there with different ratios of THC to CBD, and the effects might be different if you take it, if you smoke it versus if you eat it. So it's really, really variable. So it's a very individual on an individual basis, we decide, or a patient can decide how much to start with. But in general, the rule of thumb is to start at the lowest dose, and then you can increase it from there depending on the effect that it has on your symptoms. And if you're someone who's going to try this, definitely would recommend keeping a diary or a journal to document how much you're taking, when you're taking it, and the effect on your symptoms, to review it with your healthcare providers. So when talking to your healthcare provider, they should talk about the daily amount prescribed and these recommendations around the dosing of the cannabis. Some really important, and I can't remember, I think I have this in another slide, but some really important regulations and restrictions we'll talk about in a moment, but not sharing your cannabis with other people. They should be kept locked away from children. So especially things like edibles are really appealing to children or pets because they often come in like bright packages and are like cookies or brownies or things that look tasty. So really, really important they're kept locked and away from anyone else in the house. And important to discuss with your medical provider, are there any of my medications that I'm taking that could have drug interactions, or speak with your pharmacist about that. And this is what I was mentioning. So some other important things to note about using cannabis. So because of the side effects that cannabis has on a person's ability to pay attention and problem solve and make decisions, it can impair the ability to drive safely. And the recommendation is that there's no safe amount of cannabis to use prior to driving. Typically, the recommendations are that a person should wait a minimum of 6 to 8 hours after using any sort of cannabis before driving, and a minimum of 8 hours if it's something oral or an edible, but some suggest waiting up to a day or up to 24 hours afterwards. And also very important to note, if you're someone who is traveling, it's illegal to take cannabis across the Canadian border, even if it's legal where you're headed to. So even if you're just going across the border to Seattle or somewhere where cannabis is legal, it's a criminal offense to take it across the border. And within Canada, a person may carry up to 30 grams of dried cannabis or the equivalent. So in summary, Health Canada sets the regulations for medical cannabis use. There are a lot of different ways you can use medical cannabis. And I hope my biggest takeaway is that it's really important to talk to your healthcare provider if you're thinking about using medical cannabis or you're curious if it's right for you, because there's a lot of important potential drug interactions and side effects to consider. Thanks, and I'm going to pass it over to Renee, who's going to finish up our presentation.
All right, so thank you, Dr. Black. So I'll just be taking the last couple minutes of today's presentation to discuss an upcoming research study we have. And it is entitled Cannabis Use in Gynecologic Cancer Patients, a Pan-Canadian Survey. And before I get into any of the details, I have no conflicts of interest to discuss or disclose. So essentially, this study is being conducted at our site at London Health Sciences Centre here in London, Ontario. The principal investigator of this study will be Dr. McGee, and Dr. Black will be our collaborator. There's additional members from the Society of Gynecologic Oncology of Canada, and they're actually the study sponsor. And I am the study contact. So as mentioned earlier, I'm a clinical research coordinator here at LHSC. So what exactly is the purpose of this study? So it's to investigate the perspectives of patients with gynecologic cancer who use cannabis, and if there are barriers to patients accessing information or discussing cannabis with their cancer doctor. But we're also interested in hearing from patients who do not use cannabis and their perspectives as well. So when we're thinking about some of the main objectives of the study, so we want to establish the prevalence of cannabis use among patients with gynecologic cancers in Canada, and also to identify some of the patterns of cannabis use. So that could be type, route, duration, prescription use, etc. And some of the additional objectives that we're interested in looking into is the effect of cannabis on symptoms, to identify what sources patients commonly use for information about medical cannabis, Again, like as mentioned in the study purpose, to identify potential barriers that patients perceive to discussing cannabis with their physicians about, as well as some predictors of cannabis use. So who can participate? So our study's inclusion criteria will proceed as following. So patients with a gynecologic malignancy, having current or prior treatment with a gynecologic malignancy, being 18 years of age or older, as well as the ability to read and answer questions in English and or in French. The exclusion criteria would be declining participation. And really what we mean by that is, like with all regulated research studies, you're given a letter of information and consent to basically decide if you want to consent to participate in the study. So if you didn't consent, obviously there would be no data collected. And if you had a benign disease. So how can you get access to this study? So essentially this will be in the virtual space, and we're currently, we've submitted our study for ethics approval. So again, this is a future study coming up, but essentially what would happen is you would get access to the survey through the study's QR code or the URL link, and basically it will take you to the secure electronic data capture system, which is called REDCap, and that's essentially where the survey and really research study will be held. So essentially you can access this through, your phone, tablet, on your computer, for example. And then that's when you'll be presented with the letter of information and consent. And then if you did provide consent to be a part of the study, you would go through and answer the survey. It's up to 55 questions, and it takes anywhere from 10 to 20 minutes to complete. And then that would be essentially your participation. There would be no follow-up or things of that nature after. And how exactly we're planning on disseminating this study is through really this mixed model approach. So the first being, we're intending to recruit participants across Canada through social media, email communication, through various organizations, which I'll talk about in the next slide, as well as some support groups as well. In addition to recruitment at our site here at LHSC. And essentially where you will get access to the study, as I mentioned earlier, is through these organizations who have been wonderful enough to work with us that I have listed here, as well as Ovarian Cancer Canada, which we're very grateful for. And we'll essentially be using different social media platforms, such as Facebook, LinkedIn, Twitter, and Instagram. And essentially that's where our social media posts will be. And they'll have the description of the study, the poster where you can access the study link and QR code, for example. We'll also be using, like I had mentioned earlier, some other communication methods to get the study out there through email correspondence. On the GOC's website, there will be a subpage there where you can access information about the study, and as well as I had mentioned, through support groups. So how will you know when the study launches? Like I had mentioned, we're waiting REB or ethics approval. So essentially the organizations that I had listed in the previous slide will actually advertise about this launch with all of the study information through our study's poster. Again, through social media, email, support groups, as well as here at our study center at LHSC. And we will be actively recruiting participants for approximately 6 weeks. And the end goal of this study is to publish this anonymous survey data to contribute to the growing body of literature and research on cannabis use in gynecologic cancer patients. And thank you very much for listening and giving us your time today about our upcoming study. And thank you very much to Ovarian Cancer Canada for giving us the time to talk.
Well, thank you very much, Renee, Dr. Black, and Dr. McGee for being here with us tonight and for sharing so much information that I know all of our attendees will get and be able to take back and consider in their healthcare as they move forward. We do have a few questions, and I'll just remind everybody, if you have questions specifically, please go ahead and add them into the question and answer panel in the bottom of your screen. But just to start us off, we do have a couple of things that people were wondering about. The first one being, would cannabis use be able to be covered under insurance? And I know Dr. McGee put in the chat that you can utilize a health spending account to pay for your medical cannabis, but are there other options for people out there, that they might be able to cover that cost?
Yeah, so there aren't a lot of private insurers. You'd have to check with your private insurer to see with a medical note or a prescription, could you have it covered? Veterans Affairs patients can get it covered. I think up to 3 grams a day, which would be, for a new user to cannabis would be a large amount. And then you can access it through access payment for it through a health spending account if that's something that you have set up. But many people won't have that set up. So it can be a challenging class of medications to get funded for sure.
And the other thing I would just add to that I forgot to mention earlier is if you spend, I think it's more than $1,500 and you have a medical documentation, I think you can claim it as a tax, as a medical expense on your taxes. So you can have some coverage that way.
That's great. Thank you so much. We had a question come in through the Q&A wondering if this individual has an overactive bladder that's caused by radiation, knowing that they'd want to specifically talk to their healthcare team. But is there a type of cannabis that you know of that they might be able to talk to their healthcare team about?
Well, overactive bladder, you have a muscle called the detrusor, and it's kind of a jumpy detrusor, if you will. It wants to go when you don't want it to go. Certainly, cannabis can cause relaxation in some tissues, but I'm not aware of any particular type. I do think there's actually research that's going on in this in the urogynecology realm for some patients or by some physicians, but it's not really my area of expertise. And, as I was, as I've been reading about medical cannabis and for the kind of oncologic indications that I see patients struggling with, I haven't seen that. But, it might be worth spending a little bit of time on the internet and, trying to make your way through the weeds to figure out what is a reputable source of information. The other thing you could do is, many of these cannabis purveyors now are set up such that you can go in and ask questions similar to if you were to go in and, want to buy a bottle of wine. And so you don't always know that the person you're talking to is going to give you the right information. But in those scenarios, when I traveled in Latin America many years ago, my Spanish was poor and I didn't have a phone because they didn't exist at that time. And I would always ask 2 people and I would believe the one that I thought was more reputable. It worked lots of times, but not always. So you could try that as your method.
The healthcare team that you're currently comfortable with is always the great resource to find out any specifics and using that to go from there. That's great. We had a question around taking niraparib. And if you're currently taking niraparib, would that person be a candidate for medical cannabis use to help with some of the symptoms? Just knowing that niraparib can also cause tachycardia.
Yeah, so I wouldn't I wouldn't be taking it necessarily. So it would depend, I guess, on the symptom that you're trying to help or ameliorate. You certainly could use it, but once again, you'd want to check with your healthcare provider. You'd want to start at a low dose, whatever formulation you were using. And when we talk about medical cannabis, you can kind of take sometimes that medical word away and just talk about cannabis because of how easily patients can access this now. And so I think if you are using it, try and keep a journal of what you're doing, and then let your healthcare provider know about that. And then they can look to see, things like hypertension worsening what with niraparib, and then did that worsening hypertension correspond to the time period when you started using medical cannabis?
That's great. Thank you so much. We had heard a little bit about traveling and not being able to take cannabis with us if we were to go to another country. Is there an option to fill a prescription where we're going to if you were taking medical cannabis and needed to have that while you were away?
So I don't think that's a great question. I don't know if patients can take I honestly don't know if patients can take my prescription and have it filled, say, in the US. My first thought is no, but potentially that could happen, I suppose. I don't know if anyone has had that experience where they've had a prescription filled while they were traveling in another country. I don't know if Kristin, if you know the answer to that.
No, it's a great question. Again, my initial thought is probably not, but I actually haven't encountered that situation yet. So, and I guess it depends on where you're going. Like if you're going, so I keep picking on Seattle, but just because, it's so prevalent there that it's really easy to just go to a recreational cannabis boutique there and get what you need. But I don't know about actually filling a prescription certain places.
So it's something to do a little bit more research about before traveling, just to see if that would be a possibility.
And then you're always at the whims of the legal system. You'd want to make sure that you weren't falling on the wrong side of that wherever you're traveling.
Absolutely. Switching gears a little bit, just wondering a little bit if you can share a little bit more detail around cannabis suppositories for use with ovarian cancer and your thoughts on that.
Yeah, I mean, the rectum, even the vagina, they're great ways. They're full of capillaries, which are small blood vessels. And so drugs can easily be absorbed through these routes. That said, I haven't prescribed cannabis suppositories for patients. I'm not aware of any commercial preparations or like pharmacologic grade preparations, if you will. This sounds like something that you might get it at a cannabis boutique or on the commercial side. I know lots of patients in southwestern Ontario get cannabis from a wide variety of sources, and sometimes they might get something like this that's prepared by someone. But in that situation, it's really hard to know, what's in it and what the strength of it is. And so I'd caution you about that. You'd want to ensure that, someone was very trusted if you were going to go down that route.
And I would also just add on to that, just looking at the question, I would, talk to your healthcare provider about why you're considering using a rectal suppository as opposed to something else. Like if you're wanting to avoid the high or the psychoactive effects of cannabis, using a product that has a really high CBD as opposed to THC also might help you avoid some of those effects as opposed to the rectal route. So that's another option as well.
Wonderful. Thank you so much. We have another question surrounding surgical menopause and related insomnia, and whether the cannabis use could help with mitigating some of those symptoms.
Yeah, so iatrogenic or surgical menopause, when we do it to you as opposed to you drifting through menopause on your own, it's always harder for patients, and the onset is it's very acute, and it was estrogen today and no estrogen tomorrow, versus when you go through it naturally. And sleep disturbances are certainly something that patients complain about. Even postmenopausal patients, when we take out their ovaries, we often see that they get these vasomotor side effects, and they get these hot flushes. It's something that you could consider. I haven't looked deeply into the literature, the evidence supporting this. There's a whole host of things besides estrogen that you can use to try and treat these. And usually we start with lifestyle modifications and then move on from there. It's something that could be considered. And if you were thinking about using a cannabis-based medicine as a sleep aid, you'd want to ensure that CBD to THC ratio was, well in favor of CBD, so that you're not robbing yourself of that restorative sleep that your body needs. You don't want to wake up more tired than when you weren't taking the cannabis-based medicine.
That's great. We have time just for one last question. Why would a doctor not prescribe medical cannabis? And if they don't, can I just go out and buy it myself?
So, as physicians, we tend to practice within our comfort zone, and cannabis-based medicines and medical cannabis are something that are relatively new. And so just a lack of familiarity might be a reason why. Another reason is that, as first-line treatment for most conditions, cannabis-based medicines aren't at the top of that list. if you do want the insight of a physician, and your physician doesn't prescribe, you can go online and get a virtual appointment with a licensed physician who has expertise in prescribing cannabis, and talk to them about your symptoms, and they can talk to you about what formulations might be appropriate in that setting, and I would encourage that. Or you're 100% correct. You can go out and buy it on your own, and then I suppose you have to rely on yourself then to kind of troubleshoot and ensure that you're getting the relief that you hope to get from the cannabis-based medicine.
Great. Thank you so much, Dr. McGee, Dr. Black, and Renee for being here with us this evening and sharing your knowledge and expertise. It's really appreciated. And I know it will be valuable to all of us here tonight. I want to thank everybody who joined us here this evening as well. I hope that you had found this valuable. I'm just going